So you have concerns about the water too.
Oh, yes.
You're Michelle.
I am Michelle.
Okay.
Yes.
All right.
Helping Val moderate this group.
Oh, all right. What do we need to know? So some of us did that pre-test thing, which was really weird. Couldn't tell if you even did it right or not. But you're saying that's not necessary for CEUs? Yeah, and then they didn't tell me if I got them right or not.
Well, you guys do a post test, and then they'll probably tell you.
Okay, yeah, the pretest online was primarily for physicians. We tried to aim some at nurses, but the Quad AI is the one who chose the questions. So we were kind of limited there. For nursing theory and nursing aspect, the biggest thing that we wanted to get across to you guys is that you have to listen to your patients, which most of you already know. But for CEU credits, it's very important how do you apply this at your hospital, at your place of work, at your clinic. You really have to listen to your patient first and foremost. You know, the fifth vital sign is pain. And with mastocytosis, pain is a very big deal. It can be bone pain, it can be referred pain, very hard for them to describe, but they know that they're experiencing it. So it's very important to make sure you listen to the pain, listen to the pain threshold, you know, scale of 0 to 10. With kids, I prefer to use the happy faces because I think that is really indicative of how they feel.
Point to the face, though.
Yes, yeah, and they do have to be able to point to the face. So if you're
look at their face and score.
no, so if you're working with a newborn or facial expressions are really important in kids.
But that's class scale.
Yes, right. And so with newborns, year, 2 years, even 3, the ones who really can't say owie owie or you know I'm hurting, you really have to look at the crying. You really have to look at how are they withdrawing their arms, or what they're withdrawing their legs, and how they're reacting in their environment. Because if they're sitting there crying and nothing, you got to really look at the pain. Ask the parent. The parent knows if their kid is in pain when you're dealing with somebody who's nonverbal. Besides pain, of course, listening to your patient like we talked about. What other questions do you have in regards to patients?
Well, I know you have to, when you talk to them about the pain and the physician wants to give morphine, you have to tell them that's not a good idea. You have to be very careful with morphine.
It's important to look at what they're sensitive to and what they're allergic to. When you're working with mastocytosis patients, it's not just allergies. So many times nurses get caught up in saying, what are you allergic to? What are you allergic to? And we forget to ask if the patient is sensitive to anything. And with mastocytosis, sensitivities are as important as allergies. So that's a really good point.
I think too, when you're giving IV meds, I think you have to remember that those mast cells are sitting around the blood vessels, so you really should be giving those medications probably more slowly than you would give to an average patient.
Yes, definitely. Benadryl is one of those drugs that a lot of RNs push really quickly. And it's an awful experience for a patient. And so giving it slowly, if the patient says it's burning or if they say they're having a sensitivity to it, you know, make sure you're acutely aware of that, and always check for patency, which you're going to do probably anyway, but it bears repeating, you know, especially in mast cell patients, and infiltrate can be really serious.
And you know, there's an unusual phenomenon in mast cell patients more than in the other population, that when IV Benadryl is pushed too fast, they seem their blood pressure drops. And they really do black out. And this has happened to me a couple of times, and then all of a sudden everybody's calling the crash cart, and I wake up and I come out of it and they're like, I just gave you Benadryl, I don't know what happened. So it really has to be stressed that it has to be given, you know, either a very slow push or by drip, a fast drip. So, and the other thing is, of course, some of these injectable medications contain alcohol. So if alcohol is a trigger for the patient, that's a big concern. I had Takotsubo cardiomyopathy last September, and in an attempt to stop the severe pain, they hung nitroglycerin. And as soon as they hung the nitro, I started flushing, and my blood pressure bottomed out. Now, nitroglycerin.
Nitro.
Now, of course, your blood pressure is going to lower, but it went down to 30 over nothing. So, and I was flushing, and then I kept saying, I can't breathe. My husband was on the phone with my daughter, who's in pharmacy, and she goes, "Dad, tell them to check the nitro for alcohol." And in fact, the nitroglycerin injectable solution contains alcohol.
Wow.
So,
No idea.
It's important when dealing with the mast cell patients that the medication be as preservative free as possible. And alcohol is considered a preservative for IV medication.
so when that happened,
There's like different forms of alcohol, like propylene glycol or whatever the.
Yeah, and what if just about an alcohol swab on your skin as you're gonna?
yeah,
Would that you'd react?
yeah, if they, especially if they rub it on,
Yeah.
then I will absolutely break out and get really red and hive up. But if they just wipe it once, I'm usually okay.
Really?
But if they have an option, I tell them if they wipe it on, would they please also just take a gauze pad with water and then wipe it off, because just to clean the skin. Because if they leave it there, it'll be irritating. If you have a patient and they need a medication that has an alcohol base, then they have to be prepped in order to get that medication with the alcohol, with the prep. We're talking about the fact that many injectable medications include alcohol in the base, emergency medications like nitroglycerin and stuff. So if your patient requires that, then you have to also give them an H1 blocker, an H2 blocker, prednisone, and a leukotriene inhibitor prior to administering the medication that has the alcohol base. So that's really important information. Dextran, if you look in the emergency room protocols, and I put on the sheet here that you can get more information by going to our website and click on ER protocols. Under that ER protocols book, there is a huge amount of information, including something called the special edition for healthcare professionals. And the updated version of that will be uploaded as we print it. I should have. Is this on? Yes. The special version of the ER protocols for healthcare professionals is inside our ER protocols link on our website. In there is all the information that a physician or healthcare professional would need to look up how to stain a mast cell, to how to treat a mast cell patient, and so it's very valuable. And it also has all the telephone numbers for all the physicians that treat it in the United States. So if, for example, a patient's in the ER and the doctor says, "I don't know what to do with this patient," they can call one of the reference centers. And if that doesn't work, they can call me. And they do, at all hours. And there's a number there that they can call, and it refracts over to me. So
The PDF of the special edition is on the research CD that I just gave you.
okay.
And also the PDF of this emergency room brochure. So when you get back to your clinics, your hospitals, you can print these out, you can distribute them.
Yeah.
There are reference materials in the back if the doctor doesn't, once his hardcore medical data on where we got these guidelines. Everything is here in a nice, easy brochure. I was told at the recent ER conference that ER doctors have the attention span of a gnat, and so when you approach your ERs, when you go back and you want to do some education, when you approach them, this is what they're going to want. And it's important. Our information is on here. Our website, our phone numbers are on here. So if they have a patient at 2 a.m. and they need to contact somebody, Val answers her phone 24 hours a day. And it's a blessing. Yeah. But it's important in order to be able to save patients' lives when it comes to mast cell disorders. So this is really important.
Yesterday there was a doctor that was saying something about when you're giving epi, and I don't know if it was in mast cell patients.
It was Dr.
specific.
Castells.
Yes.
Okay, so she was saying only use.
Yes.
Okay, so these do have IV forms. So
Yeah, and actually, she said that actually just came out, and she approved this brochure.
She approved this.
Yeah, she actually approved it. She reviewed it, and I heard that, and I thought, oh, great! Now I have to revise the brochure again. And we bantered back and forth about that because we didn't know what to do about that. because we talked a lot about whether or not to put IV in there, because the reality is in an ICU, a lot of times the physician are going to administer it IV.
Yes.
And she kept saying, but really, optimally, it should be IM.
And I think that no, just grade 3 or grade 4 anaphylaxis when they come to the emergency room. If you look at this handout right here, we have the grades written down, because with mast cell patients, you can walk into the emergency room and say, I'm having anaphylaxis, and the doctor's going to look at you and say, well, you're breathing just fine, you're fine, sit down. So this is why we did the grades 1 through 4, is so that when a mast cell patient walks in, the doctor can take a look at this and go, okay, now I understand what you're saying. With grades 3 and grades 4, those are critical. The patient can crash and die. So with any anaphylaxis patient, this is what they're going to do. These are the current national guidelines for allergy. And we included them in here because once you get to that point, a mast cell patient is going to need the epinephrine. I think the current guidelines are still the IV, but like Dr. Castell said, for mast cell patients, a continuous IV infusion is not optimal. Okay, but an ICU is going to look at you, or an ER doc is going to look at you and say, well, that's what the protocol says. And that's what their protocol says. So this is a guideline for them. This is not the end-all be-all. Every patient is unique, and every patient therefore should have their own protocol. If you get a phone call from a doc saying, I have a mast cell patient, I understand that you know about this disease, what do I do? The first thing you should ask them is, does the patient have a protocol with them? Because most mast cell patients should have the protocol. If they don't have a protocol, then these are the guidelines that you should, hopefully help them go by.
Now, can I ask a question? Because, so when I go to the emergency room, my symptoms are tachycardia and hypertension. My blood pressure shoots up to like 170/100 and pulse sometimes 130, and the vomiting, the diarrhea, and the shaking. I cannot walk into an ER. My husband has to push me in. So I heard one of the doctors say if somebody has hypertension, you don't give epi because you can put him into cardiac arrest.
That is correct.
Okay, so I always tell them, please give me IV Benadryl.
Yes. And they should also give you IV Solumedrol.
Okay.
So they should give you some steroids. They should give you some IV Benadryl.
IV Pepsid or Xanax.
Yeah, I got IV Pepsid the last time when I couldn't stop.
For nausea is preferred, or Tygan, which was talked about in one of the talks this week. Those are the preferred medications that they need to give you right away, and they should all be IV. They should also administer oxygen.
Yeah, they do that, and put
just because
monitor on.
Mast cell patients tend to not know when they're in respiratory distress. And I say this because I ended up in the emergency room. We didn't know what it was. It turns out it was a mast cell attack, and I'd never had one quite like that before. It was my first experience. My heart rate and blood pressure was extremely high, but my O2 sats were in the toilet. They were 84%. I felt fine. They gave me IV Benadryl, and my sats went up to 97%. And about 45 minutes later, when the Benadryl half-life was gone, my O2 sats dropped again. And I looked at the nurse. I said, I think I'll take some more Benadryl, please. And she gave me some more IV Benadryl, and my sats went up. I had no respiratory distress. And after the sats dropped the first time, she put the oxygen on me, and it went up a little bit, but I felt better. I mean, I didn't feel like I had been in distress to begin with, but I did feel better with the oxygen. And oxygen is a very basic thing we can do for our patients that I think it can be a comfort measure.
It certainly improves comfort.
Yes, it improves a lot of comfort, and it's a simple thing we can fix.
You know what also happened? I was very surprised because I've never used epi. It's always the IV Benadryl, or if I haven't started vomiting yet, I can take the Benadryl and all the other meds. But I was in the ER. I had taken all my meds, but I still was feeling really, really badly, and I felt like I needed to go in. And they just kind of put me in a room. I don't even think they started an IV yet. They did give me IV fluids, and then I thought, I feel better. I'm going to walk to the bathroom because I really have to pee. And then I started all over again, and that never happened to me before, where I had like a rebound kind of a thing.
Phasic reaction.
Yeah, and so then I told my husband, I got to get back to the bed right now. And then I started the heaving again, and they had to give me the IV Benadryl. But that was very scary.
One of the things that we put in here is that anaphylaxis can recur for up to 72 hours. And for some mast cell patients that continually their mast cells continue to dump, especially I believe MCAD, mast cell activation disorders and mast cell activation syndromes, those patients tend to shock for a longer period of time. So they can be stable, and just as they're getting ready to walk out the door and go home, they can crash again. So sometimes if those patients seems to be really bad attack, they need to be admitted for monitoring. Even 12 hours or 24 hours of monitoring, or 23 hours if it's a quick overnight. It's really, really important to follow up and monitor those patients because they can crash again very quickly.
So they can dump over 72 hours, but then someone said today that there's a refractory period where they do have to recover to refill again. So how long is that? Do we know?
Well, that's very individual. Some patients it takes, I usually find that if I have a really severe attack, the next day I'm exhausted, but most of the time I'm not flushing, I'm not exhibiting symptoms, I just have this really incredibly compelling fatigue. And then it usually takes a day after that to start building up my stamina again. But sometimes I will have an attack that just goes on and on and on and on, where I continue to flush and continue to have ongoing mediator release. And then when that happens, I always know, look for the infection. There's an underlying cause that's causing this ongoing mediator release. What is it? Is it a UTI? Is it a Candida in my esophagus? Am I getting another bout of shingles? Because something is causing those mast cells to continually dump. And usually it's not just idiopathic. If they're continually, if I'm tachycardic to 120 every single day without any kind of decrease, then something else is going on. And so you have to start, look, it's something simple as, do you have an infected tooth? If your patients are constantly unstable and they don't just have an acute attack and resolve with the meds, then you have to look beyond that and see. Patients that have ports, do they have a port infection? If they have G-tubes, is there any pus coming out? You have to look at all the normal things. Dehydration is a really common trigger. A lot of times if I've had 30 bouts of diarrhea and I don't keep up with the potassium, I typically take 20 to 40 milliequivalents a day. Even if my potassium drops to 3.1, I'll start getting a prolonged QT interval. And as soon as that happens, it triggers my mast cells. So you have to look at every single one of the organ systems and say, what's setting him or her off. Any little thing that hits the disequilibrium part of the scale will really trigger mast cells. So you have to be super nurse. And, when the doctor walks out of the room, she goes, she's fine. You have to say, oh, just a minute, please. I disagree.
So many people don't know,
Yeah.
And I had an episode, I had talked to you last January, where I had a mast cell reaction. Due to an extreme stressful situation. And usually I take all my meds, and usually they kick in about an hour to 2 hours after I take them. And 4 to 5 hours afterwards, my heart was still racing. Usually it goes back down to normal, under 80. And I told my husband, this is not normal. My heart is still over 110, and it's been, way past the time. And I went to the emergency room, and they drew my blood, and I had an increased troponin. So they thought I was having a heart attack. And then that was like the biggest shock to me. But then I talked to Dr. Theo, because I have no plaque at all. I did a cardiac angiogram, no plaque at all. So I said, you don't need follow-up. So then Dr. Theo today said, oh yeah, mast cells are right around your coronary arteries. I was like, I had no idea.
Well, and I'll relate a personal experience with the whole being in the ER thing. I had gone to have my blood drawn. I was on interferon as a mast cell patient, and was getting ready to take a trip out east with my kids. And I took the tourniquet off my arm. I had bled, so he tourniqueted it. And I started to walk across my bedroom floor, and I hit the floor. I was dizzy. My mast cells leak. I'm a leaker, so I'm always kind of having a reaction. And so I hit the floor, and the room was spinning. And my equilibrium was off, and my head started, everything was spinning. I got nauseated. I was white. my kids got me into bed, every time I turned my head, the room spun. And I was very scared because I was like, what is wrong with me? I had an episode in the spring where they thought I had a TIA, so I'm thinking I'm having a stroke. And then I couldn't talk very well. My husband said my face was drooping, so we're thinking we're going with the stroke theory. So the paramedics show up. The police lady showed up first, and she could barely find my pulse. And my husband came home and he's like, do we give you epi? And I'm like, no, don't give me epi. And the fireman showed up, and then the paramedic showed up, and the paramedic says, oh, you just have Meniere's disease. Oh, gosh. And I looked at him, and I started, things were still spinning, but I could talk better, and I'm like, no, I have mastocytosis. And he says, what's wrong with your breasts? Oh. And I said, they're just fine. I says, I have a mast cell disease, and I said, I think something's really wrong, and I'm on interferon. And he's like, okay, well, we'll get an IV and we'll get you to the hospital. Well, they couldn't get an IV because my body had kind of started to shut down. And so when the body starts to shut down, it saves all the blood to your most important organs, which is why I was pale white. My potassium was 2.8, which is what triggered my mast cells into degranulating at a rapid rate. By the time I got to the hospital, my heart rate was 140, and my blood pressure was very high. And the doctor thinks that the body was trying to compensate for the low heart rate that I had initially, and since I did not give myself epi, it was creating epi on its own, which our bodies do that. Had I given myself epi, Dr. Butterfield said, I probably would have been really, really sick, and I could have had a coronary event because my potassium was so low.
Right.
So it's really important to draw labs and rule out other things that could have triggered the mast cells. Like Val says, infection, low potassium is a really big thing because our bodies eat up so much stuff trying to stay in homeostasis, trying to stay normal, that we get dehydrated, we get off, our blood counts get off. Always make sure that the hospital takes the time to rule out other things. Don't blame everything on masto. My potassium was low, I'd been working out, wasn't replacing my electrolytes. The interferon depletes your potassium stores, and I did not know that at the time. And so it's important to make sure everything is covered. Questions?
I don't know if it's really a question or a little bit nursing related, but I'm newly diagnosed with mast cell activation disorder, and some of your stories.
I'm talking to my daughter.
Okay, that's okay. Some of the stories are all kicking in because I know when I first had my first episode and it went on literally for months, I had heart rates in the 160s, 140s, couldn't get off the couch, massive flushing, massive diarrhea, and nobody checked anything in the beginning because I started with strep. Everyone thought I had an infection, so no one thought. So it took a long time, and it wasn't until I saw Dr. Greenberger just recently that it happened. But during one procedure I had received, and this I don't know if it's true with other MAST patients, I'm just thinking but nursing wise, I had received sedation drugs to get a upper GI. None of them worked. It didn't sedate me. I don't know if this is mast cell related or not, but it made my heart rate go from like 70 to 160, and it shot my blood pressure up, and it never sedated me. So I had it awake. And then I got discharged, and then hours later it all kicked in on the drive home, and I ended up passing out and needing an ambulance and back in an emergency room. So I don't know if that's a common thing, like if you notice that they're not, because it kept giving me more and more,
it's not
nothing.
common to have that delayed processing of anesthetic drug.
Okay.
But to have a reaction to the is common.
Okay.
And everybody's triggered by different drugs.
So you don't really know, like if you're in the ICU.
Right, everybody is triggered by different anesthetic agents. Some people have no problems with anesthetic agents. A lot of patients tolerate Versed very well. Some patients can't tolerate it at all.
My doctor gave me IV Benadryl for my EG.
You can't. Yeah, I can do Versed well, but I know that some patients can't. Can you do Propofol?
I can do Propofol wonderfully.
I did Propofol a couple years ago. It was fine with brain surgery. This was Fentanyl, Versed, and Demerol. And when I heard the doses afterwards,
Oh, well, Demerol,
Bad drug anyway.
Demerol is a mast cell destabilizer. It will degranulate
Right.
mast cells. It's a natural
Right.
one for even people who do not have mastocytosis. They can
Yeah.
have those reactions. with
Demerol's a toughie. You know, most
Fentanyl has
patients.
a really short half-life.
They don't, and that's why I was surprised when I
Right.
heard that I got it.
Right.
I never gave it.
And the fentanyl has a shorter half-life, and so that's more frequently used. And I think that's a little better with mast cell patients. We don't seem to have as much of a problem with it. If you have to go with something for pain, you want something with a shorter half-life. So if that does make the patient react, their reaction time is going to be shorter because the drug is going to get out of their body quicker.
I can tell you a real funny story. A real funny story about fentanyl, though. I had for the last 4 weeks, I've had shingles all over my trunk, and they went from this side all the way to my back, all the way to the bottom of my buttocks. And it's like the 7th time I've had shingles, the 2nd time this year. But I had developed this really unusual complication where I woke up one morning and I'm getting out of bed. I thought, oh my God, I'm 58 years old and pregnant. And I had this huge bulge on one side of my abdomen. And I stood in the mirror and I went, what the heck is that? And it was this enormous bulge on one side, all the way up here. So I call my doctor, I go in, they do a CAT scan, and the doctors are all looking at it. And they said, we have no idea what that is. So they call a surgeon, infectious disease, everybody looks at it, and the decision, which they confirmed with Dr. Greenberger, was that the shingles had invaded the underlying intestinal mucosa, and that I now had zoster of the intestines. And so by this time I'm screaming in pain. So my PCP, in order to help me, says to me, you know, you should have some fentanyl. This is too much for you. And I had been taking nothing but Tylenol. And then I talked to Dr. Weiler on the phone about her presentation. She said, Valerie, get the fentanyl. Try it. I said, I can't. I've got too much work to do for the conference. She said, Valerie, just try it. My PCP gave me 100 micrograms. And I had never taken, and what do I know? I never take any narcotic. So she gives me 100, I'm 138 pounds, she gives me 100 micrograms. So I take the patch, I put it on, I wash the dishes, I do a few things, I go to bed, I wake up at 3 o'clock in the morning, and I go, honey, my ears are roaring and I feel really strange. He goes, it's the fentanyl, go to sleep. So I get up to try and go to the bathroom. I cannot stand. So for 36 hours, I was like totally overdosed. And my husband gets me out of bed in the morning. It's like in the cartoon, hands under the arms, dragging me with my feet dragging, puts me on the couch in my room, and he says to me, I have to go to work. I have to go to work today. You have to snap out of this. And when he came back, I was like a puppet. I was just bent over with my arms dangling, and he goes, oh my God, what am I going to do with you? So he called my friend Karen, who's one of the massage therapists over there, and my next door neighbor, and they came running over, and all day they're like lifting my chin and giving me fluids. And in the middle, I had to have a teleconference with the hotel. And like slapping my face going, wake up, and I'm going, yes, it has, we need 21 gluten-free meals.
This is the nursing one.
So about 4 o'clock in the afternoon, I said to her, I'm taking this off. I just can't, I have to take this off. I felt no pain, by the way, no pain. No pain. So it was almost the middle of the next day before I was really with it again. I couldn't walk to the bathroom. My knees were like knocking like in the cartoons, boom, 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 boom. So, you know, we have, first of all, it was a significant overdose, and I probably should have had a little Narcan. But the other thing is that, you know, we're a little more sensitive to medications too. Yes. And then my PCP realized, and she called me, she goes, I am so sorry. I just realized how much I gave you, and I deeply apologize. I said, who's this?
Time to switch.
Okay.
That was great.
Thank you.
Awesome.
If anybody has any questions, you're always welcome to contact Michelle and I, and make sure that all of you fill out one of those green evaluations with your name, because
with the name. I carried on me.
Before you,
You're supposed to have a license?
yeah, you have to have it.
you can email that to Jamie at the Quad AI, and Jamie at the Quad AI, and the email address is written right on the bottom of the green, right on the bottom of the sheet.
Before you guys leave, I coordinate the medical conferences for TMS. We're currently doing 4 of them a year. So if you will give me your information, if we have one in your area and you would like to volunteer, medically adept people are always welcome. Because
we love
you guys
volunteers.
Yes, love volunteers. Because you know more about, the doctors always try to ask very medically based questions. And volunteers who aren't trained medically have a very difficult time answering some of the basic cellular questions, some of the basic questions, no matter how much, you know. So I do all of the conferences.
You do them all
over. All over. They're all over. They're wherever they decide. I'm staying this week in Boston. The ACAI is this next weekend.
You found enough.
We do the American College of Allergy, Asthma, and Immunology. You can go ahead and make the announcement. I'm just going to tell them about this.
Isn't that one?
We got to switch everybody. No, it's next weekend.
Oh, it's next weekend.
It's next weekend.
I knew it was a week apart.
I do the Quad AI with Val, and I plan the Quad AI, which is the American Academy of Allergy, Asthma, and Immunology. Okay. We do the American Academy of Pediatrics. We do the American College of Emergency Room Physicians, which I just did 2 weekends ago. So if you will email me your information, you know what? Huh? I am here. This has my email address. This is my business card, but it's my email address.
Thank you.
So email me if you're interested and tell me where you're located and where you're willing to travel to.
Thank
So
you.
that would be really great. Thanks, ladies.
So I went on like the Mass because I'm from Massachusetts. I tried to look it up under like the nursing license, but it wasn't. I couldn't find it. Plus, look at my husband's like.
Just know in Michigan we have like a nursing license verification thing, so you can just click on that and put your name
Some
in.
states don't have it. Like in Minnesota, you can't just pop it up. You have to.
I remember doing it in work because we were all signed up for the AAC and it worked. I'll try again. Thank you.
Yeah.